Today I'm going to do something a little different. I'm going to share a presentation that I gave at the Evolution of Dental Medicine Summit that was hosted by Orem this month, earlier this month in Whistler, British Columbia. Today I am going to be talking about challenging neurovascular compression as the cause of trigeminal neuralgia. I'm giving this presentation just because I've had such a response to Miss Cassidy's video that is on YouTube, and patients contacting the office saying, okay, well, how does that relate to me, or how can this benefit me because I have the same symptoms or I have the same diagnoses of trigeminal neuralgia. So I'm going to shed a little light on that based on this presentation and this case presentation. So, truth in seminar statement: I do not make money on equipment sales, nor am I a paid consultant for any dental supply company. I do utilize bioresearch EMGs as well as some other modules that they manufacture, and tech scan in a split screen display. And the lecture is HIPAA compliant, so the scans that you're going to see, I have permission from the patients to actually share this data with you. Okay, so what is DTR and why does anyone care? So DTR stands for disclusion time reduction. It is a way to measure the temporalis muscle along with the masseter muscle at the same time with bite force and bite timing. And so what you see here is tech scan data, and over here you see the muscles in real time with whatever's happening with the bite. And so the disclusion time is the amount of time it takes to get from C to D. A to B is occlusion time, C to D is disclusion time. Okay, so that is the primary therapy that is being rendered to the patients that you're going to see. All right. So this particular presentation, like I said, I went over trigeminal neuralgia, but interestingly enough, I've had patients come to me with all of these diagnoses from a medical doctor or maybe a different dentist who are looking for a second opinion. I have treated all of these diagnoses after doing a diagnostics with the T-scan and the EMGs, figuring out that yes, there is a dental concern, and lo and behold, once you take care of the organic problem, which is the bite, the symptoms resolve or greatly improve. And so again, these are just some illustrations that I got off of Facebook, where patients are trying to find graphics that visually represent what they're going through and the pain that they're feeling with their unilateral pain. So these I just pulled off the web, but they're certainly very descriptive and for someone who does not have trigeminal neuralgia as far as what the pain actually feels like. So what is trigeminal neuralgia? According to oral medicine, diagnosis and treatment, the etiology and pathogenesis are 10% of the cases we can see that there's some kind of underlying pathology that might be a tumor or a vascular malformation or a vascular compression. Okay, and 90% of these are idiopathic in nature, and so that's just a fancy way of saying, well, we don't really know why the patient's feeling pain there, but and that's a really big number, right? That's a big number to sweep under the rug. But here's the citations if you want to look it up yourself. All right. So it is known in the literature that trigeminal neuralgia can occur and reoccur in the absence of a neurovascular compression. That's been established already. Also, worth noting is there's been 3 different studies where they took a control group and an affected group. They did MRIs on all of them, and they find people that don't have trigeminal neuralgia had a vascular compression, and they find people that do have trigeminal neuralgia that don't. So there seems to be something that we're missing, and what could that be? Also, it's been calculated by Lee et al. That 99.9% of the population that presents with a trigeminal neurovascular compression do not have trigeminal neuralgia. That is an awfully big number. And so I think, all of these things kind of point to the direction that maybe perhaps we're missing something. So I'm going to go over Miss Cassidy. This is her before she had her diagnosis of trigeminal neuralgia. And she is a pretty normal, goofy, silly teenage girl at age 14, right? And this is how she presents to the office. So at this point, she's 19 years old. She had a couple of fillings done in one quadrant. Everything was okay. She went back and actually had multiple fillings done in the remaining 3 quadrants. And she started having some issues. She started having facial pain and a myriad of symptoms. And as the family goes around and tries to find a solution for her, she gets diagnosed with a number of things, which include atypical face pain, trigeminal neuralgia, atypical trigeminal neuralgia, neuropathic pain. She has to drop out of school at age 14 because the pain is so intense. And I know there's this reoccurring theme in the social media where patients are being diagnosed with trigeminal neuralgia after having dental work done. And that could be a crown, it can be fillings, it can be extractions. But basically the bite is not being managed. And so this is how she sleeps. She is being propped up by a number of pillows to be able to get herself comfortable, to be able to fall asleep. And for me, these do not look comfortable at all. So one doctor recommends that they put in a neurostimulator. Basically what this is a component with a remote that you can turn on and off. This is the basic hardware of the unit itself, and there's wires that go up and kind of confuse the brain signal's interpretation of pain to disrupt it, and that gives pain relief. We had a couple of seizures when they placed that, so they decided to remove it and did so. After that, the next course of treatment was to do a MVD, or microvascular decompression, in which an incision is made behind the ear, and they go in and they put a little piece of Teflon in between the trigeminal nerve root and whatever offending blood vessel tends to be there. Okay, so this is her left ear. Her pain was on the left side, and it did not work. It lasted for, I want to say, a month or two, and then the pain came right back. So what they ended up doing was doing a second MVD, going in and thinking maybe they could do a better job. But the result was the same. After a month or two, the pain started coming back until it was full force. Then next, she tried Botox injections around the offending muscles where pain was, to try and paralyze those muscles so that they would not be working and relax and give her some relief. And there is evidence, Botox being used for trigeminal neuralgia in the literature. The only problem with that is it's paralyzing muscle. It does not numb or anesthetize neuropathic pain. So there has to be, by definition, a muscular component in these patients that they were doing these tests on, right? And there's more than just these. I just picked out 3 random ones where Botox has been used to treat trigeminal neuralgia. This is the medications list for Cassidy of what she's on. And I have to be honest, if I was on half of this, I would be pretty doped up. And the interesting thing to me, and it's actually pretty sad, is she's taking medication to counteract taking of the medication, right? So it's important to realize that at this point she weighs 83 pounds. So her pretreatment symptoms are numerous. It's not just the unilateral face pain. There's a lot more going on. And if you're a patient watching this, you need to be an advocate for yourself and realize that trigeminal neuralgia is, yes, it's a unilateral face pain that's electric in nature and generally can be triggered by non-noxious stimuli like a cold wind that wouldn't necessarily affect me, or putting on makeup, or wrapping your head with like a scarf or something for wintertime can set off the shocks. So when you start to look at all of the things that are troubling her, you get a different picture. Like, this is bigger than trigeminal neuralgia, not from a intensity of pain position, but just the sheer number of symptoms that are going on with her, right? And so we have 27 total symptoms. Under the teeth here section, we have sensitivity to cold or ice. This is a pathognomonic symptom for the fact that there is friction, tooth-on-tooth friction going on in the mouth, and once you get rid of that, this gets better, or it may go away completely. So, a year after doing DTR, let me rephrase that. A year after we initiate DTR, we have 2 symptoms left. The other 25 are gone. And what we've done here is we've given her just a list of symptoms, and she gets to circle all the ones that are affecting her currently. And so after having the DTR therapy, she has neck pain and some shoulder aches and back aches, and that could be related to something totally irrelevant to what we treated. And it may be some long-lasting things that she needs to have a chiropractic and maybe a little physical therapy to help her with. And it's important to note that she is currently undergoing chiropractic adjustments when she comes to just have a checkup with me. So here's what we're looking at. This kind of gives you the nuts and bolts of the data that is obtained when you look at the CT scan and the bio-EMGs. So I'll go through it a little bit here. You've got these numbers on the outside, which represent tooth numbers, and then you have numbers on the inside, which represent total percentage of force out of 100 on a given tooth. So 25% of her bite force is on tooth number 9. And so the T-scan data represents force in 2 ways. One is the color of the pixels, and then also the height of the pixels. So let's say like this dark blue is significantly lighter in force than this light blue. One, you could tell because this one is taller than this one. And then secondly, here's our spectrum from high to low of what these colors indicate, right? The other thing that's important to know is that 63% of her bite force is on the left. Now, I've already said that her unilateral face pain was on the left, right? So we have a correlation there for sure. And then the green and yellow lines down here in this graph correlate to these numbers here, right? So you know that the green's going to be higher than the red, which is in both of these bites. And oddly enough, she can't really sustain a clench. and the muscles are not firing properly. These are fatigued muscles, and this is the pain adaptation model of what's going on with her. She's exhibiting exactly that because she's in pain. The body won't allow you to hurt yourself within its own control, right? And so these muscles are fatigued and not really firing. Whereas when we actually correct, and one last little thing is this icon here, this square with the red and white triangles in it. Think of this as a bubble in a level, and it can go right to left. It can also go front to back, and that this white oval with the crosshairs is synonymous to the two lines in a level that you want the bubble to slide in between, right? So you know your surface is flat. So she is to the left and anterior in bite force, all right? So when we correct that, what you see is a more even distribution among all of the teeth touching, right? You got more teeth touching, and our bubble in the level is within the target zone, very close to the crosshairs. What you also see is she is within 5 percentage points of right and left. So the important thing is you rarely ever see 50-50. I've seen it maybe a handful of times in the last 10 years. But the bite kind of works like a blood pressure or a temperature. So you won't be 98.6 the whole day. You might go up to 99 or 100. You can come down to, 96 or 97. But as long as you're within those parameters, you're okay. And so the bite really kind of works the same way. And so you see these two lines are closer to each other. And when she clenches down, she has got muscle activation on each clench, and she can sustain a clench. In other words, the force is not oscillating in each one of these bites, right? She can clench and hold, which she could not do before. All right, so here I was following her with some different photographs throughout, before and throughout therapy. So look at her eyes here at visit 1. Quite different than the first follow-up. 4 weeks in between these two visits. And then her last follow-up in treatment, and she looks like a completely different person, right? Also, we notice forward head posture changes a little bit. And so this is her on the day of treatment, both of these, about an hour and 30 minutes, hour and 20 minutes between how she came in and how her bite changed. And I want you to look at the distance between the ear and this green line, which is taken right at her ankle. Her head is forward more in the habitual bite than it is in the DTR corrected bite, right? She's standing straighter. And that's something we notice quite a bit in TMD or TMJ patients, is this forward head posture, which has already started to correct itself just an hour and 20 minutes from picture to picture. The other thing that was really interesting that she shared with me is she lifted up her shirt, and this is the first follow-up to DTR. This is not prior to, but she lifted up her shirt and she said, look, my hip has rotated and it's not as prominent on this side. The other thing is this part of her abdomen is very flat. This part of her abdomen is pretty curvy. And so after we do DTR and before we start chiropractic, we notice that there's still, it's not 100% resolved, but she doesn't have this rotation that she has here, right? This is still more curvy than this side, but not as dramatic. And she's starting to get a little dimpleization right here on this side. So when we observe this, I have her go see a NUCA chiropractor here local and try to unwind her even some more. And this is how she's sleeping. This is mid-treatment. You notice that she's not propped up. And she's got a pillow down here on the floor. She's got 4 pillows that are still on her bed, but she's not sleeping propped up like she was prior. So again, the day of treatment, she's 83 pounds. 1 month after, she's already gained 10 pounds at 93 pounds. And then here we are at 110 pounds about 5 months after we started the initial treatment. And there's some significant changes, obviously, that are going on. The poor girl is not skinny because she fears gaining weight. She's skinny because she can't eat. And so imagine a teenager that can't eat. And so as soon as she's able to chew and function properly, she fills out and gets curves on her, right? So here we are. I'm just kind of going over my findings with her as far as her posture change, which I've already shown you. And then this is Cassidy down in Mexico. I think this was the family's first vacation in 4 or 5 years that they were able to take and enjoy. And it's wonderful to be able to give that back to her and her family. So if you want to watch Cassidy's video, her whole story is about 40 minutes long, and you can go to my YouTube channel if you're not already on it, and look this title up, and you can watch from beginning to end how we treated her and the change that we observed. All right, so maybe I just got lucky on that, and maybe she really didn't have trigeminal neuralgia, even though it had been confirmed with an MRI that she had a neurovascular compression. So remember those studies we talked about at the beginning of this little presentation, and how patients could be in pain with trigeminal neuralgia but not have the neurovascular compression, and there were people that had the neurovascular compression that didn't have trigeminal neuralgia. So this is a bit of a quandary. So what I have observed in the last several months is a number of patients that have come to me with the same, okay, I've been diagnosed with trigeminal neuralgia by a neurologist prior to coming to your office, and this was confirmed with an MRI. The neurovascular compression is present, okay? And one of these patients had Gamma knife, didn't work, and there have been 3 MVD surgeries. All of these were treated just in the same way that I treated Cassidy, okay? So let's just take a look at this. So here we are. This patient has got 60% of their bite force on the left and 40% of the bite force on the right. The affected side is pain on the left, okay? And you can see the left line is higher than the right when the patient bites down. Betty did have Gamma knife surgery, and it didn't work. She had an upper denture with lower natural teeth. So what she really needed was a denture adjustment, and she got Gamma knife instead. So I went through a series of adjustments to allow the muscle physiology, the inflammation, the swelling to inner joints and muscles to subside, and that took a number of adjustments to get her feeling better. And here we have another Cassidy T-scan data where she is anterior and to the left. This is a pre-treatment scan, I think on the day that we actually started treatment. Looks slightly different than the one before, but we always take new data prior to making adjustments. And so her affected side is on the left, and there's a correlation of 76% of total bite force is on the left. Chester's trigeminal neuralgia is primarily on the right side, and 52% of total bite force is on the right. Danette, her pain was on the left. 73% of her bite force correlates with what's on the left. Here we have another patient whose pain is on the right side. along with the bite force correlation. Pain is on the left, bite force is on the left, 70-30. This patient had occipital and trigeminal neuralgias. Pain was on the left, trigeminal wise, and it's basically 60-40. So here we have another patient who's diagnosed with trigeminal neuralgia, unilateral pain on the left, where he's got 77% of total bite force is on the left. Also, again, notice that the black line oscillates. This is total bite force. He can't sustain a clench. Muscles really aren't working. This one's a little different. This is a pregnant patient with trigeminal neuralgia. She has a bite timing issue. This is not as evident as a bite force. Basically, her disclusion time between C and D is quite extensive. It should be less than half a second. Okay. This one is evident as well. Lottie does have a YouTube video that you can watch. You can watch and see how her treatment transpired. But unilateral pain on the left, bite force is very high on the left. And again, she doesn't oscillate as bad, but she can't sustain a clench either because she just starts to fall off. Okay. Joe, unilateral facial pain on the right hand side, and he's got 70% of total bite force is on the right hand side. Larry, unilateral facial pain on the left. He's basically 60-40, and if you look at the black line, he can't sustain a clench either. Rosie, unilateral facial pain on the right. So this becomes really, really redundant at this point, and I think I've kind of driven home the point. But the question is, at what point do you say, okay, well, maybe this is not etiologic in nature anymore? Do you have to see 20 of these consecutive patients before you're like, hey, I think I've got something figured out, and no one's listening? Do you have to have 100 of these? Do you have to have a double-blind, randomized, controlled, longitudinal study with 5,000 patients? The reality is, even if I had the last one, it's going to take 50 years for the medical and the dental community to move on this. And what happens to the patients that are suffering now? Well, so sorry, you lose. Basically, we're going to either cut you or give you drugs because that is what is deemed as acceptable treatment for patients that have trigeminal neuralgia. And so this is interesting. This is a patient that came to me, actually came from the East Coast, and he's got 80% of his bite is on the left side. Now, what is important to note here is that this tooth right here, which has, 32% of total bite force, this is a crown that was done, right? And so patient didn't know the bite was off like this. He knew that something wasn't right, but he couldn't tell, the dentist, and the dentist let him go home with 30% of his total bite on this one tooth. So this hurts. And unfortunately, he decided that he had to go to Oregon, here in this office, to get it fixed. And so the question I have, if you're a dentist watching this, is if you knew that this was the problem, would you let it walk out the door like that? And the answer is no, of course you wouldn't. But this is what happens day in and day out in dentistry when you don't measure. Patients can tolerate the inconsistency for a while, all the way up until the point that they can't, right? So here we hit in the front and then slide over, and this little indicator is telling us where the problem is, right? It's where all the force is. So once we actually correct the issue, fix his bite, then he doesn't feel any pain. He starts getting a resolution. And this is probably still just a little bit too high, but this is the first day of treatment. He's back to basically 50-50. And remember, I said 5 percentage points is acceptable for right and left. And he's got basically blue and green levels of force all the way around the arch. So, accepted therapeutics for trigeminal neuralgia. I took these off of Facebook, these two pictures. This woman's being prepped for MVD, and she wanted to share with other people that are suffering and people that maybe don't suffer, but help them understand this is where the incision is going to be made, right here. And then this is gamma knife. So you have this attractive halo where these screws are screwed into the forehead, right, so that you cannot move. And then all of these little cylinders around this colander looking apparatus are pointed right to the trigeminal nucleus inside the brain, and they're irradiated with gamma radiation to kill that kill the pain signals that are coming into the brain. Now, all of this may be needed for some patients. However, if I'm a patient or a doctor who's seeing something that I think fits the bill as trigeminal neuralgia, I would go for what's the most conservative and what fits the easiest treatment to do. It may not be easy to get to, but certainly is conservative. So let me back up. One interesting thing, so when you see bite force like this, there's a number of ways to treat this patient. One might be, well, we can move the teeth to a point where they're hitting more over here. We could also build a night guard or a splint that evens out the bites. The only problem with that, and you could get to this point with a splint for sure, and the patient would certainly feel better. However, you take the splint out, this is what you chew with. So the neurology gets activated again, and while the pain does reduce, it doesn't get as better as if you just fix the bite and the patient is balanced 24/7. The other thing that's nice about doing this is you don't have to rely on patient compliance for the therapy, right? Here, if the patient doesn't wear their night guard, the pain symptoms are going to start ramping up. So patient compliance does become an issue, especially if the appliance gets broken, the dog gets a hold of it, it gets lost, it gets left somewhere when they're traveling, and then you basically have to start over. If you just fix the bite, you don't have to worry about any of those problems. Plus, this happens in probably 3 to 4 visits in patients that are not as complex, maybe 6 to 8 in patients that are a little bit more complex, that may take a year to complete, but there's no phase 2. So, getting a nice splint made is a viable therapy, except it only works when it's in. So then you still have to do phase 2, which is moving the teeth to this position or doing a full mouth rehab or a full arch to solve the problem. All right, so the other question I get a lot is, how far down the body does the effects of occlusion take place? So what I want to show you here is on the left side of the panel on the left side of the screen is the habitual bite, and on the right side of the screen is the DTR bite. These are done on the same day. This is pre-treatment. This is post-treatment. All right. And so what you see is this patient who has basically 75% of total bite force on the left, unilateral pain is on the left, and you can see our little cursor is to the left and behind our treatment zone, right? So here we basically have that fixed plus or minus 5%, which is our goal. And so the other thing that I'm showing down here is MAT scan. It's the same technology, same company, different application. Instead of it being a bite, you're standing on it with your feet. You take your shoes off, and you can see that 58% of total foot balance is on the left foot, okay? And 42% is on the right. After we fix the bite, we're basically 50-50. And we've had improvements all the way down to the bottom of the feet, and these are on the same day as the first treatment visit. So the neurology changes very, very fast. So just to finish up, as I said, all of these were patients that were diagnosed with trigeminal neuralgia, but you also see people that are coming in with cervical dystonia, Meniere's disease, migraine headaches. This patient wouldn't allow me to make a video, which I've got to totally respect. And then vestibular and ocular migraines, I'm actually treating a patient now. So it'll be interesting to see how this turns out, because she does have a bite imbalance, but let's see how the presentation of symptoms gets addressed as we're taking care of her dental concern. So all of these, as I'm seeing, are not some just random mystery. We don't know what it is, but you get diagnosed with this because we really don't have anything else to diagnose you with. We've kind of ruled out everything. But when you look at other symptoms that are adjoining, there's a lot of overlap between TMD and Meniere's disease, as far as the ringing in the ears, the vertigo, the fullness in the ear, and some hearing loss has been documented too. So it's good. The change is coming about by patients being their own advocate, not because there's 30 years worth of DTR literature that's been presented, although a lot of this stuff has just come out in the last probably 4 or 5 years. That patients coming in with this looking for more answers are finding out that the occlusion, despite what's being promoted in literature and in some dental schools, that it's not a cause for occlusion, is factually wrong. It can be, doesn't mean that it is, but I think before I were to set myself up to take a whole bunch of medication or get cut on, I would rule out something that was pretty innocuous. Thank you for watching, and I appreciate your time.